Hi all.
who have oncogenes can be so effective.
Okay. Yeah, I think that all makes sense. I guess the big question that I'm sure is on the minds of a lot of our audience is, so we have these targeted therapies, like you said, they kind of shut down this abnormal signaling and, eventually in certain instances lead to cell death. I guess how the heck do we then enter into this whole thing where we have, especially in advanced disease, this idea that resistance is inevitable? I guess, where does this resistance come from? Why, if we have such effective therapies, are they able to kind of escape that?
I think this is a very challenging question. And I think a lot of different ideas and concepts and theories have been proposed. I think before we get into how cells develop resistance, maybe let's talk about types of resistance that we see.
Definitely.
When patients, and here I'm focusing on lung cancer, and in particular, I'm focusing on oncogene-driven lung cancer. Patients get started on tyrosine kinase inhibitor therapy, which I'm going to call targeted therapy, but just recognize that there's a difference between the two.
Hmm.
We see three categories of resistance. We typically see something like on-target resistance. That's the first category. And here what we're seeing is that there are mutations that have evolved in the intracellular ATP binding pocket. So where the drug is going, the cancer cells have started to evolve mutations that prevent the drug from binding as well as it used to. Lung cancer, the most well-studied example of this is the EGFR T790M mutation.
Yeah.
It thankfully doesn't occur much anymore because most patients are using a drug called osimertinib, which was specifically designed to prevent this mutation from occurring. But in the years past, when we were using first generation EGFR inhibitors, one of the major problems we would see is that patients would get on a drug like erlotinib or gefitinib. These were kind of older EGFR inhibitors, and that their cancers would evolve a very specific mutation called T790M. And this effectively prevented the drug from going into the binding pocket and competing with ATP effectively. So that's called on target. And ALK mutations have their own. The most well studied in ALK is G12. And all that. So you can go down the line of different oncogenes. They tend to have different on target resistances.
Sure.
I think a more complicated resistance profile is something called bypass signaling. So that's category 2. And what's happening here is very interesting. What's happening here is that the original drug is still working effectively and is still binding the oncogene pathway. But what's happening is the cancer cell is starting to co-opt other growth signaling pathways and use them to survive. So using EGFR as an example, if you give a patient osimertinib, in the resistance setting, a bypass signal that can sometimes get turned on and has been well described is MET gene amplification. And so MET is another growth pathway. What's
Hmm.
happening is the cancer cells are basically finding whatever tools are in the toolbox to survive and turning on other pathways to do so. So that's one. And then the final resistance mechanism we should cover is something called lineage transformation. Fortunately, this is rare, but this is fairly serious when this occurs. This is when a tumor changes its entire cell type. So in lung cancer, most of these oncogene-driven lung cancers occur in a type of histology called adenocarcinoma. But under the right settings, this can sometimes transform to something like small cell lung cancer. And this is a very complex phenomenon. There's a lot of research into this space, but that is a third mechanism of resistance. Okay, so we covered resistance. So the question is, how do we get there? And I think this gets to a central concept that I'm interested in, which is drug-tolerant persister cells. Because it turns out that resistance doesn't just, it is inevitable for every patient, but the timeline is not inevitable. And so I think one thing I've always been struck by is, why do some patients not develop resistance for 10 years and some patients have resistance within 18 months? So clearly resistance occurred, but why there was this huge lapse in time is an understudied problem and is an area of research.
Yeah, just to circle back, so I guess we have three main categories of resistance: on target resistance, which is that ATP binding pocket that we talked about that the TKIs bind to. There's a change there, or there's a bypass mechanism like with MET, another RTK, right, where all of a sudden that growth signal is coming in not through, let's say, EGFR, but through MET. And then lineage transformation, people have heard about small cell transformation. I guess to my mind, the first thing that pops up is like, well, it seems that all three of these mechanisms sort of involve the cancer cell changing or evolving in some way. And I guess to your point with drug tolerance is why, how the heck, if we have this really good drug that binds, prevents growth, kills the cells, where do these cancer cells get this ability to evolve these sort of mutations to give rise to resistant disease?
It's a really good question. And I think sometimes when we think about the drug tolerance phenomenon, it's helpful to go back in time and look at some of the historical origins of this concept. The term drug tolerant persistence actually originally comes from a 1944 study by a scientist with the last name Bigger, who discovered that there is a certain bacterial subtype called Staphylococcus aureus that in culture could not be killed even by escalating the dose of penicillin. So this was not what was interesting about this article is that he hypothesized that there was a subpopulation of bacterial cells that were able to survive penicillin, but it was due to their lack of growth rather than any mechanism of resistance. So what he first observed was that when you gave high doses of penicillin to some of these bacteria, they actually regressed and took a more dormant phenotype. They basically stopped dividing the way they would normally do in a culture.
Mm-hmm.
They started adopting properties that appeared to make them look more dormant. And when you compared their characteristics to the parent bacteria, they didn't actually have resistance to penicillin per se, but they have somehow adapted changes that allowed them to tolerate penicillin. And I think this became a really central concept when we're thinking about lung cancer cells. And I can cover more detail, or if you have any questions.
So that's really interesting, just to make sure I follow. So, I think everybody's generally aware of like staph infections, right? That's the bacteria that we're talking about here. And so I guess the idea is that there's certain cells within that population. Let's say the people take the antibiotic, the bacteria responds, it kills off the cells, but there are some cells that are able to stick around.
Yeah.
And so these drug-tolerant persister cells. Okay. And so I guess if you were to sum up, like, why are drug-tolerant persisters so important? What role do they play in terms of, people are on these TKIs, they work great, and then all of a sudden you have a scan and they've stopped working, the disease is growing again?
Well, I think to anchor it to the clinical world, while these drugs are amazing and patients do report pretty dramatic improvement in symptoms, I would say that it is, in my practice, the norm that most patients who get started on these tyrosine kinase inhibitors, when we do a first scan assessment, which I typically do 2 to 3 months after they start therapy, most of these patients will have a significant improvement in their cancer, but it is very rare to have what's called a complete response to their cancer, meaning that there is no identifiable cancer on imaging. Most patients will have, in my experience, something like 60 to 70% reduction in the size of their cancer. Some of their metastases might have gone away, but there is this population of cells that you can still see on imaging, even after 3 months of therapy. And so it begs this question, why we have this effective drug, it's blocking the mutation at a very specific site. Why doesn't it result in 100% cell kill? And the reason it doesn't result in 100% cell kill is this phenomenon of drug-tolerant persister cells. These are the cells that have, through mechanisms that we're still trying to understand, adapted and become tolerant of the tyrosine kinase inhibitor. And I think a really critical concept for the audience to understand is that these are not resistant cells. In fact, if we were to do a biopsy of cells treated with a tyrosine kinase inhibitor 2 months after treatment and compared it to the parent cell, they are genomically identical. There are no resistance mutations here. So this is not a resistance problem. This is actually a separate state that the cancer cell finds itself in.
Okay. So I think just to hammer home that point, because I think it's so crucial. I think what you're saying is, hey, look, there's this intermediate state of drug tolerance. And that's really kind of, if you will, like the beginning of the problem, like the reason why we don't just have curative targeted therapies.
Correct. Yes, that's what I've come to appreciate through clinical practice and just my own research in this space. One of the challenges with these drug-tolerant persister cells is that it is therapy specific, and this makes the whole analysis of this field complicated. So there's a distinction I also want to draw between drug-tolerant persister cells and dormant cells.
Okay.
So a major distinction is that drug-tolerant persister cells can only, it's in the name, but I think it's worth stating explicitly, can only arise in the context of a therapy. So it's not inevitable that the cells are going to find themselves in this sort of quasi-dormant state. They have to, in fact, have received and been subjected to continuous selection pressure. So if we're using a kind of evolutionary model, the drug acts as a selection pressure, kills off, let's say 70% of the population. But evolution is very resilient, and 30% of the cells, 20 to 30%, will find a way to adapt to this hostile force. So the question is, how do they adapt? And I think we've learned a lot in the last 5 to 10 years about drug-tolerant persister cells. They have some very interesting and unique properties that are very different than the parent cells. Specifically, they come in 4 categories. So they tend to have what's called epigenetic and changes. And epigenetic just means these are not genetic changes that we would see in the resistance setting. So when I talked about T790M earlier, or the on-target resistance mechanisms or bypass signaling, those are genomic resistance mechanisms. Epigenetic is different. These are usually methylation patterns. These are not things that we can typically just find by doing repeat biopsies and doing genetic testing.
So you're saying like, hey, look, these drug tolerant persisters, it's not like they have a different genetic wiring than the drug sensitive cells. It's this epigenetic phenomena or certain changes outside of the genome that are resulting in them being able to survive despite the fact that you're taking your targeted therapy.
Yeah. Epigenetic and sometimes what's called transcriptional changes. So we talked about epigenetic changes. They also have cell cycling changes. So we do know that these cells don't divide at the same rate as untreated cells. They also don't divide at the same rate as resistant cells. So, and we'll come back to cell cycling. That's a really critical concept, I think, when you're thinking about drug-tolerant persister cells. We know that they modulate the tumor microenvironment, and there are ways that they participate in immune evasion. I think this is something that we're still not fully clear on the exact mechanisms. There's been a lot of interesting work in this space. And then finally, they have metabolic changes. So as they slow down, as they divide less, they also adopt what's called an EMT, or an epithelial mesenchymal transition. And so they get what's called stem cell-like features. And so this is really interesting when we think about drug-tolerant persister cells, is that they go from having this very clear, defined phenotype to this almost in-between state where they can kind of go this way or that way. And that is very consistent with slow cell cycling. And so all of this makes them very difficult to target, because these are adaptive changes to avoid the effects of the drug.
Okay. So you mentioned they're basically like 4 distinctions that between drug tolerant persisters and just the normal sensitive cells.
Mm-hmm.
How are they kind of able to keep going despite the fact that they're no longer able to grow through that pathway?
It's a fascinating question, and it's a really challenging question.
Mm-hmm.
Observations that at least our group has done. So I collaborate with an investigator named Sabrina Spencer at CU Boulder, who's done a lot of work in this space as well. And what her lab has shown is very interesting. So if you take cell cultures, within 72 hours of putting these cells and exposing them to osimertinib, they already start to have transcriptional changes. So the adaptation to targeted therapies is very quick. And what we start to see in these cells is that there's a subpopulation that emerges that has all of the features I was just talking about: slowed cell cycling, epigenetic changes, metabolic changes. I'm not going to get too much into tumor microenvironment, because when we're talking about cell lines, they're not in vivo.
Mm-hmm.
But one of the things that I think her lab has shown that's really interesting is that these cells are trying to divide. They're just stuck. They're stuck
Okay.
because the drug is essentially blocking their ability to promote growth signaling pathways and turn them on. And so what you see is drug-tolerant persister cells tend to have signs of elevated DNA damage because what's happening is they're trying to replicate, but they're not able to sort of escape the pressure of the drug. And so you see upregulation of pathways that help recognize double-strand DNA breaks. So you see upregulation of pathways like ATM, ATR. This all suggests that these drug-tolerant persister cells are actually trying to find ways to replicate and get around the stress that's being put by, in this case, a drug like osimertinib. We also see, and this was some very nice work that an MD PhD student, Varuna, did in our lab, that cyclin D1 dependent cell cycle is very important for reentry. And this suggests that you can, in theory, there are drugs that block cyclin D1. These are drugs that typically affect CD4 inhibition, could be used for these circumstances. But the take-home message I want to have the audience understand here is that ultimately a drug-tolerant persister cell, one of its principal goals is to get out of this dormant state and get back into cell cycling. So there is a bottleneck that's sort of natural and convergent for all drug-tolerant persister cells. They have to be able to go back into the cell cycle. That's the difference between drug-tolerant persister cells and true resistant cells. True cells that have acquired resistance are cell cycling normally. Drug-tolerant persister cells are not cell cycling normally. There's a lot of stress that's put on them to divide correctly. And I think that presents some very unique opportunities to understand what are their cell cycling vulnerabilities. And if we understand them, and again, there are some pathways here that seem to be implicated, like ATM, ATR, Fanconi anemia pathway, and then the cyclin D1 pathways. These are potential avenues to target these cells at a point when they're vulnerable to therapies that they may not be vulnerable to in the resistance setting.
Okay. So just to make sure I'm tracking, so we have, I guess, your work in Sabrina Spencer, right? Yeah, not Sabrina Carpenter. That'd be unusual.
That would be
Are, yeah. So basically, you guys are have found that by being on the tyrosine kinase inhibitor, these cells want to divide. The cancer cell wants to, but it's kind of stuck. And so as a result, there's a buildup of DNA damage, and there's certain pathways then downstream of that allow it to kind of divide despite that, or just upregulated because of this DNA damage that are kind of unique vulnerabilities. So maybe a way to eliminate them and therefore prevent resistance from arising?
Potentially, yeah. I mean, that would be the ultimate goal. I think an important distinction to also highlight here is that these pathways that are being upregulated are pathways that are DNA damage repair mechanisms. And these are occurring because a cell is trying to cycle but cannot, or at least has not figured out an opportune way to do so. And these pathways are being upregulated and expressed so that a drug-tolerant persister cell can re-enter the cell cycle. But a key point is once they're in the cell cycle, once they've re-entered and have become resistant, they don't need these pathways. So you will probably not see increased ATM, ATR, cyclin D1 pathways in a true resistant cell because they are in fact cycling. So it does point that just to the conclusion that drug-tolerant persister cells might just have very different vulnerabilities than resistant cells.
Okay. So I guess then I think the question that'll be on everybody's mind is great. You guys and other groups have identified these sorts of targets, these vulnerabilities. I guess what's kind of the holdup on translating this stuff to the clinic? Why, why are we kind of stuck where we are?
Yeah, the hard part here is that a lot of these changes occur very early. So I had mentioned that some of these MAP kinase transcriptional changes are occurring within 72 hours of starting the drug. There's no way we can biopsy a patient 72 hours after they just were diagnosed with stage 4 cancer. I think there's a lot of practical challenges in doing the sort of longitudinal biopsies that we would need to confirm whether drug-tolerant persister cells have been eradicated or present. So there's that. I think The other issue is just the fundamental kind of concept related to trial design, which is that I think a lot of oncologists want to give therapy up front and then not really add or intensify treatment until there's some kind of sign of progression.
Mm-hmm.
And what has been challenging is to find a group of patients that are what I would call high risk. Again, that's a very fluid concept, and do an intensification type trial for those patients. This gets to a bigger conversation about how should we design trials? What are the appropriate targets? As I mentioned earlier, some of the DNA replication markers that we're seeing in drug-tolerant persister cells, I think are unique to the drug-tolerant persister state. I don't think that in the resistant setting, we're going to see these. And I don't think it would be viable to target them in the resistant setting. Getting buy-in from regulatory agencies to do a trial that is sort of adaptive, dynamic, is challenging. So there's that. There's a practical hurdle. I think the third thing is, even if we wanted to follow patients, I think we still need to recognize that this is all very experimental, and this may or may not pan out. So those are challenges I see.
So just to run through them again. So I guess the first one is we're saying we start therapy, great. We know we have our targeted therapies, but then, and I think this is the like big paradigm shift that you're kind of highlighting here and that your work is focused on, is that it's this state of tolerance, like after you've started, you've killed off whatever, everybody gets those good scans where the population is decreasing, and then people are stuck at, I think what's commonly referred to as like a minimal residual disease state, where you probably hit this drug tolerant state, you have these drug tolerant persister cells. And one of the big problems there is just like, well, we don't know exactly what the pathways are that they're relying on or confirming, for example, that an ART inhibitor would be good here, because just the practicality of like getting that, nobody wants to go and do a biopsy at that point, and just designing a trial like that could be a nightmare. Is that kind of
That's
one
accurate.
big?
In the EGFR mutant lung cancer space, there's been a lot of excitement about a specific trial called FLAURA2, which was basically adding in chemotherapy, carboplatin and pemetrexed with osimertinib upfront at the beginning. And what that trial showed was that patients who got the chemo and osimertinib combination had a longer overall survival than patients who just got osimertinib by itself. So there is some clinical data already that shows that maybe an intensification strategy might make sense. What I'm pushing back on and what I'm arguing is that while that trial used carboplatin and pemetrexed, and that's great, that's a well-established chemotherapy, do we really know that that's the best chemotherapy combination for patients? And do we really know that those two chemotherapy drugs are probably what are going to affect the drug-tolerant persister cell population the best? You can make an argument that maybe, and again, I'm just picking a random therapy, but
Uh-huh.
substitute carboplatin with a carboplatin. Or specifically, why not substitute pemetrexed with a drug like a topoisomerase, a topoisomerase inhibitor? So, I mean, this level of granularity hasn't been explored. So while we do know that there's some value in intensification, I think what I would like to see the field move towards is really trying to understand what the vulnerabilities are in these early states, and then tailor therapies that make sense. So for example, if we find that drug-tolerant persister cells, for whatever reason, upregulate TROP2. I'm just picking a random receptor tyrosine kinase, but let's say that happens.
Uh-huh.
We actually have TROP2 agents available
Uh-huh.
that can target these drug-tolerant persister cells. And the key concept is you just do a focused, intense treatment for a limited session. This is not indefinite TROP2 therapy. This is, we start the osimertinib, we get to some period of time, let's say 2 to 3 months after. At that period, we hit it hard with the drug that we think works for drug-tolerant persister cells, and then the patients go back on the osimertinib. And in my mind, this is functionally and no different than the work that's being done at our institution. MD Anderson is also doing this with consolidation surgery and consolidation radiation, right? The
Uh-huh.
logic here is fundamentally the same, but we're using systemic treatments based on what we know about drug-tolerant persister biology.
So, Dr. Patel, to that point, What do you think? Because it's just something I actually discussed pretty recently with Dr. Roto, Julie Roto, and I was just thinking about it in the context of the North Star trial and Bright Star and some of those other similar efforts of could in like in a legal metastatic setting, could you have a trial design where you start with a TKI, you have that induction phase, you then do surgery, you get the tissue, you could analyze the tissue and see kind of what pathways are upregulated. And then, I mean, it'd be challenging, but maybe you could start with just like what you think theoretically would work, but at a certain point, alter the or intensify treatment based upon what pathways you see upregulated.
Yeah, I think that's a great question, and I hope that that's something that the investigators in Bright Star protocol think about, because I think it's a unique opportunity. There are patients, just to define oligometastatic for the audience. It's well, actually, it's an evolving concept, but I think in the most generous sense, it is patients who have 5 or less metastatic sites
Hmm.
diagnosis. So we would typically consider this low volume disease. To be honest, there's not a clear consensus definition of what constitutes oligometastatic, but we know that these patients, when we treat them with targeted therapies, some of them may be amenable to surgery. And then the question is, what do you do with that surgical tissue? It's a good question. I think exactly the points that you've outlined are what we should be doing. I think it'll be hard to use in an individual patient, use that information to make adaptive designs. I think what I'd like to see more of is just that, drug-tolerant persister cells, sort of evolutionarily speaking, have similar problems. So they have to figure out how to get back into cell cycling because they're not cell cycling. They may do so by upregulation of a variety of receptor tyrosine kinases to sort of facilitate reentry into the cell cycle. They need to make metabolic changes to adapt to the drug. And then I think the big area that potentially could be very transformative, but we have the least amount of information on, is how do they participate in immune evasion? What kind of tumor immune microenvironment changes are happening at the level of the cell environment? That, I think, is the area, certainly in my research, that I have the least understanding of, but I think potentially pave the way for some very cool immune therapy approaches in the future.
Hmm. Are there, I guess, sort of any, in terms of your work, are you then looking towards, I guess, what's the future direction that you're kind of interested in terms of how do we approach these drug tolerant persister cells and hopefully, wipe out a subpopulation or some of them?
Mhm.
I guess obviously we highlight those challenges and translating it to the clinic, the regulatory challenges. I think they're just challenges, like you said, with trial design, where you're going to have to, in an ALK setting, you're going to run that, if it's a PFS or OS, you're running that thing out for years and years and years. So I guess, do you think it's going to take some incorporation of, a biological endpoint like this sort of ctDNA elimination or?
Yeah, yeah, it's a good question, and agree, because thankfully, using ALK as an example, our targeted therapies are so effective that many of these patients are living years after their therapy, some well into 5+ years. So if you're trying to design a trial showing that some kind of early intervention extends PFS and OS, it might be a decade before you get that information. And so do we have other markers that we could use? ctDNA is one that you raised. It's a very interesting marker. We do know that patients who have detectable circulating tumor DNA after starting targeted therapy, those patients are really high risk because most patients clear their, well, actually, I wouldn't say most patients clear. Some patients will clear their circulating tumor DNA, but the ones who fail to clear their circulating tumor DNA have a higher risk of recurrence and progression. So I think maybe identifying that population as a high risk population first, and then using that, some of the biology that we're learning about in our work. And we're not the only group doing research on drug tolerant persister cells, but I think as a community, if we can understand and gain some insights into specific vulnerabilities, then designing trials, even they can be really short, simple phase 1, 2 studies to just see, does this work? Is it safe? And go from there. I mean, I think the future can be very bright here. And I think we can think very creatively about how to think and approach these cells. And the model I point to is the evolution and use of a BCL2 inhibitor called venetoclax in acute myeloid.
Mm,
Yeah. That has been to me the North Star. And I think we can, as a lung cancer community, use some of the insights that the malignant hematologists in our group have explored.
wow, that's a really interesting point, and I think something for all of us to think about. Dr. Patel, I want to respect your time. I know already past the top of the hour, but I just wanted to touch on a sort of last thing that I think comes to mind. Obviously, you're at the University of Colorado, and Dr. Camage recently announced that he, in fact, is an EGFR patient. I know Dr. Camage has touched so many patients in the community and is just seen as not only an expert but somebody who really forms strong bonds with their patients, and somebody who patients really come to trust, admire, and have that sort of bond with, emotional bond with. So I guess number one, just sort of expressing our sympathies. I know you guys are a close-knit team, and it's obviously a big blow for anybody to get one of these diagnoses, but it's kind of even crueler when it happens to somebody who's dedicated their lives to helping others with this disease. Are there any sort of research efforts that you're working on or other things going on at the University of Colorado that you'd like to highlight for patients and caregivers in the community to learn more about and consider supporting?
Yeah, thank you for that. And I obviously I had known for a very long time, but I think it was always Ross Camage's story to share, and I think he is going to reach a point where he wanted to share that with the community, and I respect that decision. It was obviously very hard for us when he was first diagnosed, and I think one of the things I'm noticing as I'm seeing the community as a whole react to the news and process it is thinking that there's different stages of grief, and how that shock stage was where myself and some of our team members were 3 years ago. And I think we've kind of come to a new space with in terms of efforts we're doing at the University of Colorado. We spent most of the podcast here talking about drug-tolerant persister cells, which I think are very important. I really do think this is going to be an avenue of research that can help patients extend their time on the targeted therapy. And I would love to see targeted therapy time horizons that are similar to what we see in chronic myelogenous leukemia.
Mhm.
We should be striving to get 15 to 20-year time horizons for patients on targeted therapy. That this should be a norm. So that is something I feel very committed to. We have a robust cell line program here and an organoid model development program here, which has been really impactful for some of my work. I have an investigator-initiated trial looking at amivantamab for patients with ALK, ROS, and RET targeted therapies. And some of the ability to generate cell line data and organoid models to sort of help inform what we're seeing in the clinic has been instrumental. And then I think a work like this can't be done without an environment that supports the research mission. I'm very fortunate that at University of Colorado, I have fantastic colleagues like, Dr. Paul Bunn, Dr. Aaron Shank. We have two newer colleagues, Dr. Weber and Dr. Kyle Kincannon from MD Anderson. I think as a thoracic oncology community, had a very collaborative environment, and I'm, really, really thankful for that, and also just thankful for the community and the trust they put into not just us, but really just the thoracic oncology research enterprise. I think we can't do this without patients also advocating for newer treatments, and that sense of urgency also kind of helps me get up every morning and try to do something different.
Yeah, well, thank you so much for being one of the thought leaders in this space and kind of thinking about how can we push it from being, EGFR, I think real world data, you got like 16 or 18 months PFS to talking about, survivals that are 10 to 20 years. I think that's music to patients' ears. And so thank you for thinking about this problem. It takes people like you to kind of think, how can we think outside the box and attack these at sort of its state of vulnerability rather than constantly playing defense. So Dr. Patil, thank you so much for your time. I really appreciate it. It's very insightful. And hopefully we can have another conversation down the line about maybe progress in this area or something else. I think it was really helpful for patients. So thank you.
Thank you. It was a privilege to chat with you and chat with everyone here.
Great. Well, take care.